the key to this, it's when you denervate something, it causes spasticity. Well, some of it is intuition, some of it's experience, and some of it is, I wonder. I don't have a way of reducing dopamine coming out of the basal ganglia, but I do have a way of telling the basal ganglia to take a nap. 40 and 988.
I love that you talk about looking things up, because it's okay to not know. It's okay to pause and research and not have all the answers.
And my personal belief is that every condition, every injury that you have is there to teach you something.
Thank you for subscribing to the Frequency Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about, or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn McMakin.
And we got the white t-shirt memo.
We did. How does we have we don't know how we do that. We just do that.
We just do it. I'm going to close the door super quick because dogs are going to
have an opinion
and then come out. Make a decision.
We keep mine downstairs.
Well,
it's just quieter that way.
Well, UPS has a way of coming between 3 and 4. So
yes. For us, it could be almost anything that Eleanor has an opinion about.
She's just doing her job.
Yes, she is. And she has done her job. The varmints in the backyard are down from maximum to moderate. Yay.
We all have a job to do, whether it's our guard dogs or our hippocampus. I mean, there's vigilance happening everywhere.
True. I did something this week that is truly impossible.
I feel like this is the common theme of the podcasts.
Is it? Doing the impossible?
with you, with your stories anyways, yes.
Okay, so this time was for really, it's something you guys are gonna have to search it. It's called Meige, Meige syndrome, and it is spasticity in the facial muscles, causing the particular patient I saw, when she talked, well, by the time she got to me, she's had it for 4 years. By the time she got to me, when she talked, her eyes slammed shut. Anytime she vocalized, her eyes slammed shut. Now, before, they would just slam shut randomly. Her face muscles were spastic, tight. Some patients, if you guys are looking it up on the internet, the picture that's the most disturbing is the patient whose tongue spastics out. And the only way she can get it to stop is to put her hand on the other side of her face. Okay, so she also was light sensitive. That's vagus. She also, it's vagus because the vagus constricts the pupils. So if you're light sensitive, it's because the vagus is not doing its job. And so that says your vagus is gone. Her gag reflex was completely gone until she gave up on Western medicine and found a chiropractor wherever she lives that did something that got her vagus nerve working and got her gag reflex back. Yay. But the vagus still wasn't fully functional. And so pretty much if you look up Meige, Meige, it's the muscles and structures that are affected, every cranial nerve that comes out of the Pons. And in her, the other symptom she had was that her shoulders were up like that and had been, for 4 years. So we ran concussion in Vegas. This is the first day. concussion in vagus, her neck turned to pudding. We ran the vagus, and the key to this, and I don't even know that I'm going to present it at the advanced because it's just such brain anguish, neurology. It's when you denervate something, it causes spasticity. And I called my favorite consulting MD and said, okay, the muscles are spastic. And he said, well, if it's denervated, it's flaccid paralysis. And I went, no, no, no. If you have a myelopathy, the first thing you get is you lose descending inhibition, and you have increased tone or spasticity. When you have a stroke and you lose input from the sensory motor cortex, you have spasticity. And the way we fix that is increased secretions in the sensory motor cortex. So not only had I never treated this condition, I'd never heard of it.
Okay, that was going to be one of my questions was, how much did you know about this before?
Zero.
Okay.
So I'm talking to the patient and I said, well, we got to go back to first principles. Denervation. So if your sensory motor cortex stops talking to your muscles, you get spastic. So that's why your face is spastic, which means the facial nerve and the I can't remember which nerve it is. It's two, or it might be the facial nerve that makes your eyes slam shut. That's that nerve. Anyway, they all come out of the pons. And so I thought, well, we're going to increase secretions from the pons. Okay. So now the treatment that had been done before over the last 4 years, those of you with weak stomachs might want to turn the volume off for a few minutes. They inject Botox into your eyelids. Really sorry. And so they,
I mean, would make sense when you're thinking about.
well, if all you can treat is the end problem and you have no way to address the brain, then of course you just want to stop the spasticity. You can't Botox your whole face.
Yeah.
So we did increase secretions in the pons,
Okay.
right? And we looked up what neurotransmitters are used in the pons: acetylcholine, GABA, serotonin, and norepinephrine. Well, the only one that's inhibitory out of those four was GABA. Okay. I didn't have any GABA with me. So that first day, by the end of 2 hours, her eyes were better. They weren't slamming shut, but they were closing when she talked. Vocal cords, vagus. So there's a connection between the vocal cords somehow and the pons. It's in the medulla.
Okay.
And then the next day, yesterday, she came in and she said, I looked stuff up last night and everybody says it's the basal ganglia. Okay. Well, if you lose secretions from the basal ganglia, you get a resting tremor and you call it Parkinson's. But in this case, the basal ganglia were overactive, right? So it says slam. Okay. So we know that increased secretions in the basal ganglia works in Parkinson's. I wonder if quieting the activity of the basal ganglia would work. So we had one machine and CustomCare with Pons repair running. We had concussion in vagus and then just vagal tone running. And then the other part of the brain that was involved was the cerebellum. So the cerebellum is to vigorous in delivering the message
Mhm.
from the basal ganglia to the pons. Anyway, so there was another precision care with quiet the cerebellum. And everything else we do, we increase secretions from the cerebellum,
Hmm.
right? To get muscles coordinated. Well, we want to tell the cerebellum, calm down, just
Right.
dude, chill.
Yep.
So we've got one machine quieting the basal ganglia, one machine quieting the cerebellum, one machine running increased secretions in the pons, in addition to the machine that's treating the pons for poor baby,
Yeah.
the basics. And then there was one machine on just increased secretions in the vagus, because the other inhibitory neurotransmitter, it was serotonin.
Mm.
Okay. So day 2, that was the treatment protocol, was 1, 2, 3, 4 precision cares, because I wanted to be able to sort of, control what we were doing. And then concussion in vagus and vagal tone and Pons repair. So that was 1, 2, 3, 4, 5, 6 machines, all from her neck to her abdomen. Had them all running at once. And at first her arm went squishy, and then her arm firmed up. And she started blinking more. It's like, it's too much. Let's leave the Pons alone and turn down the drivers.
How did you make that? I have so many questions, but how did you make that distinction just there?
Okay, this part is in the advanced. It's like, how do you know?
Yeah.
Well, some of it is intuition,
Yeah.
some of it's experience,
Yeah.
and some of it is, I wonder.
Yeah.
Right? And it's like, it just didn't feel right. Her arm was really squishy because I had my hand on her forearm.
Yeah.
And then all of a sudden it firmed up. It's like, okay, I'm doing something wrong because her arm firmed up and her brain doesn't like it.
Right.
So what are we doing? Let's leave the Pons alone for a minute. And I forgot to tell you that before the treatment, I had her I brought chewable GABA
Mm.
for her. And Joseph went out and got a bottle of 5-HTP to give the precursors to serotonin.
Mm-hmm.
Didn't have time to give her that. So all we supplemented was GABA. Okay. I need you guys to think about this. How you
We
doing?
started with a bang, just saying. Like,
Yeah, I know. It's like,
we
hang
are
in there.
concentrating.
You're doing great. So and we learned this once again by mistake.
Yeah.
And that was a patient who well, never mind. If I do that, I'm going to lose you.
Right.
So if you're going to force a structure like the pons to secrete GABA,
Mm-hmm.
you will secrete GABA. Okay, GABA is made inside the little brain cells by the precursors to GABA. And when you run 81 increased secretions in the pons to make it relax, it runs out of substrate. It runs out of the stuff that you are forcing it to secrete.
Yeah.
So it's like, let's just stop 81 in the pons, increase secretions in the pons, and let the chewable GABA have some time to build up a supply in the brain. I don't know how long that takes, but we'll find out. So we quieted the basal ganglia, we quieted the cerebellum, turned on increased secretions, kept increased secretions in the vagus to increase serotonin, because those two are the inhibitory neurotransmitters that come out of the pons. How do I know all this? It was on I Googled it. I searched it. Push Safari. What neurotransmitters are in the pons? And there are 4 of them. And they're right there. And it's like, okay, I can do GABA. The vagus will create serotonin in the brain, and some of it's going to get to the pons. So those 2 are there. I don't have a way of reducing dopamine coming out of the basal ganglia, but I do have a way of telling the basal ganglia to take a nap. 40 and 988.
Yeah.
Okay. So we did that for probably 20 minutes, 30 minutes. And then her arm firmed up again. It's like, I wonder if it's ready. And then we turned on again, increased secretions in the pons. Her arm turned to total pudding. Increased secretions in the vagus to increase serotonin, if you guys remember that diagram from the Vegas webinar. And 40 and 94, the day before, quiet the medulla and quiet the accessory nerve. Her shoulders were still down. They never jumped back up. So the medulla was fine. And we ran that for probably another 45 or 60 minutes. And as she talked, her blink rate got slower and less. It didn't slam. She just blinked.
Right.
And so I lent her an office CustomCare. She's here from across the country. I lent her an office CustomCare and our magnetic converter and gave her a bottle of GABA, chewable GABA from Designs for Health, because GABA is hard to absorb. And cranial nerve. Thank you, Al. Cranial nerve 7. Yeah, that's the one. And it's in the pons. So give her 5-HTP and ordered on Amazon, on my Amazon account, 5-HTP from Thorne, which has just a little bit of B6 in it, plus the chewable GABA, with the instructions to take them at night, in the morning, night, in the morning, and then I'll see her tomorrow. But this nighttime program ended up being 5 hours, right? Because it's concussion in vagus, Pons repair, quiet the basal ganglia, quiet the cerebellum, and then her childhood abuse was horrific. And I said, we got room for emotional frequencies. Anger? No, not really. What? We have anger, fear, grief. What you got? And she said, oh, totally fear. I have never ever in my life felt safe. So I put 970 and 27. And there's also a 970 and 23. So 27 is just terror, which is what she felt all the time she lived at home. 970 and 23 is a more yin kind of fear, worry, over concern. And I described that, and she said, that's what I have now. What if this doesn't go away? She hasn't been able to drive because her eyes will slam shut. She can't drive. And she can't cook dinner and talk. We had her with her eyes open her mouth and go, ah, and her eyes stayed open.
Wow.
Oh, so you can make sound as long as you don't make words. And then we sort of traced that nerve pathway. So speaking involves so many parts of the brain. Wernicke's area, well, actually the cortex. What do I want to say? Wernicke's area, which words are they?
Yeah.
And then Broca, which I know what it does, but it escapes me. And those all have to work together, and they send the message to the facial nerve to make your tongue and your face muscles. All right, with all that input for speech going to the pons, there's too much input to the pons, and it's denervated. It can't, it pushes it too hard, and the muscle spasm. The basal ganglia say absolutely not, and the cerebellum says, I can stop this. So it was, by the time she left, I looked at her and I said, you have to go look in the mirror, because her face muscles were completely relaxed
Yeah.
and she was blinking, not spasming. And it's like, yeah, I, it, and it, and we just searched it. I didn't even know what the syndrome was.
Right.
And then when we looked at what was involved, it all came out of the Pons. Okay, so we have a frequency for that. And then she came in the second day and said, yeah, but every piece of medical literature says it's basal ganglia being too active and the cerebellum being too active. And it's like, well, I know for sure we can turn them down, because remember that case last year where somebody turned down their midbrain to the point that they decompensated?
Right.
So we know that 40 and a brain part works and does that thing. And so I could do 40 in the basal ganglia with some assurance that it was going to work, and 40 in the cerebellum with some assurance that it would work. We'd already done 40 and 94 and her shoulders relaxed. So, and then mileage had taught me that if you're going to use 81 and a brain part, you have to provide the the precursors or the substrate for the neurotransmitter that you're going to force it to secrete, or it runs out of stuff and it just goes, I'm sorry.
This is sort of piggybacking on Dr. Billica's, you got to put in a little good before you take out the bad, or you have to support a system before you ask it to do something for you.
Well, and when we run 81 on the brain part, we are forcing it to secrete.
Yeah.
That is just, that's what we do. It actually works, which is, it makes your brain hurt when you think about that, but it actually works.
Well, we see it. I mean, that's what the wipe and load protocol from the sports course evolved into. And after all these years later, I still get emails like, it worked on blah, blah, blah. I'm like, yeah, it works.
Yeah. So that's,
So,
I'm,
okay, where do I even start unpacking your little tale?
it's, you go back to first principles, and it's okay to look stuff up.
Right,
I've never heard of it.
right,
What part of, well, all the muscles that were involved in the pathology came out of the Pons. Well, I have a frequency for that.
right.
She said, well, they think the prefrontal cortex, that was the other thing. When the basal ganglia are too active, you get OCD.
Hmm.
And she said she had talked about, she got a bug bite and started scratching and then couldn't stop scratching. And it went on for months.
Oh, wow.
And it's like, okay, that's a basal ganglia. Got it. Because we looked it up. It was,
Okay, so I love that you talk about looking things up, because it's okay to not know. It's okay to pause and research and not have all the answers, and the practitioners that are listening that love to be prepared, you can still be as prepared as possible. That's called having a search engine and a textbook at your fingertips that you can, or somebody like yourself that I can text.
Well, and I had the neurology textbooks back in my shelf, Kendall and Schwartz, my favorites, and they were useless.
Right.
They didn't talk about brain parts. They talked about, well, Botox is what we use. It's like that's when I closed the book, put it on the floor under a chair, and forget about that.
Right.
And I enrolled the patient in the process of figuring it out.
Right. And I think that is an important, I know in my practice, it's an important component to create that symbiotic relationship of, I don't just work for you, we work together to formulate a plan that we both love in your healing journey. So, and some patients don't want to research anything. They just want to be gifted certain pieces to do, and that's fine. And then you've got some patients that love that.
It's a collaborative journey, and she had been through so much and seen everybody. And the way she, believe it or not, the way she found me was she was on a flight. She never buys first class tickets, but this time the upgrade was only $200, and she thought, why not? So she's sitting in first class and she's sitting next to somebody. And this person had been a FSM patient. And they started talking as you do. And he said, where, what's going on? So she told him about this condition that she had. And he said, there's something you have to try.
Wow.
Told her about the book. So she got the audiobook and made the appointment, I guess 3, 4, 5 months ago, 4 months ago, and then showed up, and it was, I'm not easy to find. I don't have, right? And
I think we're getting harder to not find. I think with this podcast and cross-pollinating through social media and all the practitioners that we have that are also just talking about what they're doing and not being afraid to promote results. I know my athletes have kept things very hush hush because it's their secret sauce, and I love that for them. However, I also love when they promote their success stories, because that is really how we learn what works, what doesn't, and if something works. I think that the big thing that I love to follow is for how long. How long do we have before things will come back? Is it permanent? Do we need a custom care for management? I think we all need custom cares for managing whatever we need. I was just working with somebody yesterday who had a total knee replacement and had some issues with that healing and has very limited flexion and is the perfect patient on paper and had the perfect surgeon and did the perfect rehab, and things just didn't turn out the way she had hoped. And so you can have all these things in place. And when she sees me and we do manual therapy and we run FSM and we do corrective exercise, we get an extra 10 degrees of flexion, we get no pain. And I said, this just will be part of your management process now. You do your exercises, you do everything else to maintain health. Let's add this tool. And she said, but when my knee gets all better, then what? I'm like, well, then we'll program it for other things, because you're a 70 some odd year old athlete who is going to be as active as you possibly can. So I think that that's also the conversation of, yes, your custom care will need updating. How often depends on many different things, healing, life.
well, and the top 10 things, and sometimes it's even the top 5 or 6, but the top 10 things are what they need for the condition they come in with.
Correct.
The next 20 things are common cold, wound healing,
Yeah.
soft tissue acute, soft
Yeah.
tissue week 1 to 4, DOMS, skin anti-aging, flu respiratory,
Yeah.
common cold throat, common cold sinus, common cold combo,
Right.
and shingles.
Right.
Shingles is the one thing I'll let them treat a checker at Safeway. Anybody. It's like what have you got? Oh, I have shingles. It really hurts. It's like, you would you mind? I have this thing. So that's that. And then anybody that has minor male children gets fracture, ankle sprain.
Let's add girls too, just because
Yeah,
I'm
yeah,
very
well, girl hockey players, yeah. So ligament strain, tendonitis, shoulder pain, knee pain, low back pain,
Right.
ovarian cysts. I mean, we call the last half of it FSM first aid.
Right, exactly.
And
You
then
pack them up with what they need, and for my male hockey players, I give them exactly what you said, the first, 3 or 4, what they found me for. The next, whatever that I think they're going to need in the immediate future. And then stuff for their spouse or their kids or whatever else, just because they have it. However, now having the software where we can send protocols has really made my life a lot easier, because sometimes practitioners or sometimes clients who have 20 protocols get overwhelmed with having to scroll through 20. I'm like, okay, let's give you 5 in a month. I'll push you a few more.
yeah.
We'll change the order and whatever we need to. So that has been a really great update in technology for us.
And one of these days we'll have a unit where you can just, type in the whatever and it'll come up. But for right now,
It
we
works.
have the best unit on the market. And so she went home with a 5-hour nighttime program
Right.
that ended with the emotional stuff.
Right.
And I'll find out tomorrow afternoon at 2 o'clock where we are.
Right. Maybe I missed this because I felt like I had to concentrate right off the bat. How long has this person had this condition? How did it start? How long was she
Just
misdiagnosed?
a lot of stress, like really horrific stress.
Yeah.
And there are different triggers depending on who gets it. But for her, it was just unreasonable amount of, there's only so many abusive, narcissistic, sociopathic people you can have in your family before your brain goes, okay, I quit. I give up. It's done. I'm out. And so it's been, I think, 4 or 5 years. And the thing that just is hard to get my head around, is this thing is untreatable. There is no medical model that that allows them to do what we did.
Right.
Believe it or not, one of the treatments is Ambien, and it is a benzodiazepine receptor agonist, and benzodiazepines are used as muscle relaxants.
Right.
Simple muscle relaxants. Valium is for spasticity.
Right.
So she's found a doctor in her area that would put her back on that. She had been on it for years, then she moved to where she lives now. And it was, oh, well, and they took her off at cold turkey. That didn't help. But now it's like, well, all we have to do is increase serotonin. Let the vagus do that and give the vagus the building blocks for serotonin. And then at nighttime, you make the receptors more receptive.
Mm-hmm.
And 5 years. I mean, it just still, I can hardly wait for tomorrow.
Us too.
It's next week, we'll find out. And
What's interesting to me, the more I teach FSM, the more I'm teaching people to think about how we got here. Forces the envelope to think of every condition of how did it get here, and how did it turn into, and I think that's kind of how you reverse engineered how you got to the hypotheses that you did treating this patient, is walking it back and not just saying, okay, the blinking, okay? And then the quick fix would be Botox, or muscle relaxant. Like that is taking it one step backwards, but it's not finding the whole story. Whether or
Well,
not it holds will be interesting, but
yeah. And it's like one of the possible symptoms in this condition, if you look it up, is auditory hyperacusis.
oh, okay.
Hypersensitivity to sound,
Yeah,
hypersensitivity to light. So hypersensitivity to light is the vagus doesn't work, and she didn't have a gag reflex. That also says you got to turn on the vagus. Well, we got data says we can do that.
yeah,
Hypersensitivity to sound, and if you open that page in Netter, it it shows everything that comes out of the medulla, everything that goes. The Pons is just right uphill from that, and it just keeps coming up. So it must be time for me to learn about it, which,
it is so interesting, and I think you warned us about that when that happens, when all the sprained ankles jump on a bus and come to your office at the same time. And we've been talking about the ponds like crazy lately.
well, it's
Depending
so
on what's
what,
happening.
2 weeks ago, I had somebody that was having microvascular ischemia to all of the branches of the Pons. And it's like she didn't have a stroke,
Right,
but sort of TIAs, microvascular, little teeny clots that just sort of make that portion of the brain hungry for oxygen for a period of time.
right.
It was pretty fun. It's just, it's so cool to be able to think that way and then to have the frequencies actually do what we think they're doing.
Right.
It's like, and putting all the pieces together. So it takes us back to the advanced. Danielle said, we have more in the people signing up this last
Yeah.
2 weeks, but it's the whole first morning is about how do you think about it?
Yeah.
And because without that, the whole rest of it is just useless.
Yeah.
It's pretty fun.
Yes. And carrying that torch forward with the rehab courses, that is the foundation. And I'm so excited. I'm so excited. I'm so excited about them. I just sent my slides to Kevin for my advanced talk. And
Woohoo!
so like last advance, I had to thank Dr. Musnick for forcing my hand to do the hip. And so this year I have to thank you for convincing me to do the knee.
Well, poor knee just gets caught in between the hip and the foot, and
Well, I've got I'll send you the slide that you can take. I'm sure you'll find it funny. And it's instead of middle child syndrome, it's like understanding
yes.
the knee, because you can't treat the knee without the hip and without thinking of the ankle or the foot. And, when we're doing assessments and the rehab courses and the sports courses are a lot of assessment based, whether or not the assessments are just reminding people to go back and assess, because yes, smush is great, but I want case studies and I want data and I want people to go back and show their PTs and their doctors, look, now I have 10 more degrees of flexion. And how did you get that? Well, this is what we ran and this is what we did. Why did you do that? Because we thought about why was it scarred in the first place? Why are they afraid to move it? And so the range of motion is like, don't forget about that. It's that's your proof that what you're doing is working.
And doing, because the other patient I have this week is she wants everything better in 4 days. And it's like, that's not going to happen.
Right.
But she said, oh, I still have pain when I do this with my neck. And it's like, well, we have your original range of motion in your neck. Let's see what it is now after. I mean, all I did was run neck pain. I didn't even work on her neck manually.
Yeah.
Just ran neck pain because she had so much else going on. And her range of motion had increased in flexion by 20 degrees. Extension had increased by 10 degrees. Lateral bending had increased by 10 degrees in each side. Rotation was already at 90. She said, well, it hurts when I do that. And I said, then don't do that. You are already at the end range. It is unreasonable to want it to go farther than it's supposed to.
Right.
You're supposed to be able to rotate it to 70. You're rotating to 85 or 90. Of course, it's going to hurt when you get to 90.
Yeah.
Okay.
Yeah.
Bless their hearts.
And right. And sometimes it is having those conversations of what is realistic. Going back to my person with the total knee replacement, what is realistic? This is not your knee anymore. This is a brand new knee. And we have to be realistic with what is possible and make sure that these gains are possible. And we talked about doing the impossible, but sometimes we do have to remember a titanium knee is a titanium knee.
Yeah. Well, and what does the sign say? Be realistic, expect a miracle, but be patient. The impossible takes slightly longer than the difficult.
Right.
And yeah, yes.
Right. And sometimes as a practitioner, we get caught up in certain things not moving as fast as we would like them to. And we have to be realistic with ourselves and our scopes of practice and healing and there's all the other things that people are doing when they're not with us that we don't know if that is working against the progress. And sometimes your progress takes off and sometimes it's a bit slow. But one thing I wanted to illuminate today with metrics, and I was just talking about range of motion, but watching somebody's mood and watching somebody's confidence as they're healing should not be ignored. So people who are healing from there's been a whole bunch of shoulder surgeries lately. I guess that was preparing me for my own daughter's recovery. But the patients that can't wait to get out of the sling, I get so excited for. And they're like, why are you so excited? I can't wait to take this thing off. I'm like, because that is confidence. That is confidence saying, I can't wait to move. And this is what we want. We want our
Well, and
patients.
it's the expectation that you are going to recover.
Correct.
It's a lot easier to work with somebody who has the expectation that they're going to recover,
Yes.
as opposed to, oh, I'm doomed. The
Right.
other important thing is she'd already done the emotional work.
Yes.
She'd already done the internal work to
Help with healing.
deal with
Yeah.
her condition.
Yeah.
So that, and we actually were talking about that when she was pretty stoned on the table. We were talking about that, and I said, you've already done the hard part. Then all I have to do is fix the tissue.
Right.
Because if you are okay with who you are and what you have going on, then you are okay with yourself. And my personal belief is that every condition, every injury that you have is there to teach you something.
Yeah.
And then the question is, did you learn it?
Yeah.
If you've learned it, and then you find somebody that can help you, then you can get rid of the condition and keep the wisdom, keep what you learned, keep your patience and compassion and all of the things this really inconvenient, difficult, like you validate, yeah, this has been pretty awful. And
Yeah.
what'd you learn?
Right.
So it was really fun.
Yeah. the fact that we as practitioners can keep learning and learning with every patient and condition, to me, is the exciting part for the professional student in me that loves to make PowerPoints and loves to learn things. This was the best possible gift for me as a professional because nothing ever gets boring. Nothing ever is complacent. Nothing ever stays the same. So the people who are listening that haven't been to an advanced or a core in a long time, things are different. And
No.
you should just come to
Yeah.
Arizona and hang out with us
Yeah.
and see what
It's
you've been missing.
amazing. I mean, and thinking about neurotransmitters, there's Bilica's lectures so that the molecules of behavior, so that you have an idea when you look on your search engine and it says acetylcholine, you know what that is.
Right.
Epinephrine and norepinephrine, you know what that is, and you know the precursors.
Right. And those are the molecules of behavior are
Behavior.
that's still available on the
Oh, yeah.
FSM
As a matter of
website.
fact, we were giving it away for free instead of selling it
Yeah.
for the month after Roger died.
Yes.
And I think, are we charging for it now?
They've been taken down.
Okay. Yeah. So now it's still
This
still
page is
there,
still there.
but it's for sale. And
And it's great.
yeah, that's
And we have a
pretty good.
question. We have a question.
Yeah, we
We're out
do.
of time
Annie,
already.
of course we do. Waiting to see this 27 tall, thin male client from a brief, insufficient description of a situation, considering hospitalized younger, 10 years ago, pneumothorax, heard this today, thought only briefly about the following possible issues: inflammation, trauma, scarring, lungs, nerve, lungs. It's pneumothorax is when something pokes a hole in the pleura. There is a frequency for the pleura, I think it's 87, the fascia, autonomic nervous system. But tall and thin, the other thing you have to consider is spontaneous pneumothorax there's a hole, something pokes a hole in the pleura. It's usually knife, a broken rib. You have to have a hole in it where the air that should be on the outside gets in the inside and it collapses the lung on the side that is punctured. Well, okay, he's 87. Okay.
No, I think he's 27. 87 might have been the frequency for pleura.
Oh, pleura. Okay, 87 is the pleura. The patient is 27. You have to check him for hypermobility. The first thing you do is check his Baton score. It doesn't make any sense for a 27-year-old male to get a pneumothorax from no place without a broken rib. Something
So that's where, I mean,
makes sense.
I don't know what her scope of practice is. I certainly wouldn't say I'm treating your lungs. However, we can treat diaphragm, we can treat intercostals. There's checking the Baton score for hypermobility. Like these are all.
Well, 124 is much younger. So I don't know what his complaint is now. Usually, if you've had a pneumothorax,
She said it happened 10 years ago.
yeah, but once you've had it, the way they fix it is to pump air in there, and then they used to use talcum powder. They don't do that anymore, but they put something in there to make it stick. Yeah, to make the pleura stick to the lung and sort of glue up the hole. So his complaint is difficulty breathing when singing and during exercise. Well, he's got scar tissue in the pleura, but you have to check him for hypomobility and then find out what caused the pneumothorax in the first place. Oh, I broke my rib. Okay, then you have a cause. Well, nothing. So I have a patient who said that her son, she's hypermobile. Her son was a swimmer, and he's had 3 pneumothoraxes, 2 while swimming, 1 when he was a jet pilot. No rib fractures, no nothing. So difficulty breathing when singing and exercise, find out how they repaired the hole in his pleura. And you're on the right track. It's not the lungs, it's the pleura. The lungs may be scarred, but the difficulty is going to be, can they expand? And then the other question is, what about the vagus?
Mhm.
Right?
Well,
But
when I'm working with people with breath, with expanding, so talking about pleura, all the scarring, the diaphragm, I don't know if you remember treating me in Hawaii, that's what we had kind of walked through, pleura, diaphragm. And then when you're talking about diaphragm, you have to look at the vagus as it's coming through that area. So, and then learning to breathe after was a whole different. So there is also going to be that kind of disbelief. What do you mean my lungs can move this way? What do you mean my ribs can move this way and that way? And there's space and confidence and
well, and you
but
have to coach them. They're laying
yes,
on their back on the table,
yes,
and you've treated scarring in the intercostal nerves, and
yes,
you've treated scarring in the pleura, and
yes,
you've treated scarring in the vagus and scarring in the diaphragm. And we really can't, speaking of Hawaii and you, we can't forget our friend, the kidney fat pad and the kidney,
yeah.
right? So, and then you coach the patient. It's
Yeah.
like, okay, I want you to, here's my hands on your ribs. I want you to
Go
inhale
up to my
and
hands. Yeah.
push my ribs, my hands out.
Yes. Yes.
Huh?
Yes, and it's almost like teaching somebody to contract their transverse abdominis or like a pelvic floor muscle when you have no idea. So putting someone's hands just gives you such great proprioception. Oh, okay. And then it's that confusion. It's like you can do it. It is such a great cueing point for any
Yeah.
type of breath work. So
Yeah.
yeah, a little bit of an onion to unpeel there,
Good
but
luck, Annie.
yeah, hopefully that helps.
Yeah.
Um, Yeah, the hypermobility, especially when, the first sentence, tall, thin, that was the kind of right.
Yeah.
And again, it's just certain things with FSM just get put on your radar right away. And things like Ehlers-Danlos and hypermobility are just some of the things that we get to look for because of who we are and how we can treat it. And I think it's missed by a lot of people.
Yeah, for sure.
Yeah.
And one of the other patients this week had a complaint of, I have trouble with memory. Well, she's hypermobile and she has a vestibular injury she didn't know about.
Right.
And she said, I'm concerned about my memory. And it's like, well, in the advanced, I actually did 4 slides on a mini mental status exam. Draw the clock, give them a time,
Mhm.
and 3 words to remember. First,
Mhm.
apple, chair, cat, and then draw the clock, make the hand. So one has to be short, one has to be long.
Mhm.
And then what were the words?
Right.
Well, she didn't draw the clock right. She drew, I told her 10 minutes until 2.
Mhm.
She drew 2 o'clock
Okay.
and she got the words right, but they were in the wrong order.
Mm.
And you repeat them more than once
Mhm.
so that they have it in short-term memory.
Right.
And okay, then, well, we will redo the test at the end of the week and see how she does.
Right.
So it's the advance this year is just, I had time to put in the things that you need to evaluate
Yeah.
the patient before, but also evaluate your progress.
Yeah.
Pretty cool.
The progress evaluation is pretty profound when, especially those of us who have been doing it for a little while, when you see how far you've come, how far you still have to go,
Yes.
what's possible. But again, like that, the reframe of what I get to learn, I think is just so important. And it reminds me of the first class I took when you get your laminate and you're looking at all these frequencies and your first core and you're still so overwhelmed and you're like, you don't need to memorize any of this stuff. Like,
No.
okay. And it's amazing at how much you do end up retaining. And it's amazing how there's still so many frequencies that I use all the time that never stick in my head. And I have to always look them up. And that's okay too.
Yep. Yeah, exactly.
Well, we have a few minutes left. I don't know if we answered all the questions or not. I think we did, which is great because I
Yeah.
feel like we never get to
That
things. I hope
It
we
means
finish.
everybody else is as overwhelmed by my case report
Well, I was
as,
gonna say, I think your story has left a lot of people just kind of marinating and swimming in what you did and how you, again, how you unpacked it and how you thought your way through it is very inspiring. So if you can unpack and we can unpack together a complex case like what you just did, that gives us hope for all the little sprains and strains that most of us see
yeah,
on a daily basis.
yeah. I was really happy to see somebody's, shoulder the week before from an auto accident. It's like, oh,
Well,
goody.
this is easy.
This was fun. Well, actually, it was a little bit more difficult because it was an auto accident.
Right,
So all of a sudden, I went back to my roots from 25 years ago when I saw auto accidents.
right.
And we had her booked in a 3 hour slot. I was with her for 5 hours. She
Yeah,
was my last patient of the day,
right,
but the history is completely different when
right.
it's trauma. I was an IME.
Yeah.
So when you got in the car, did you have any pain? Yes. And it was from what and how long had you had it and how
Mhm.
much did it hurt? And then she said, oh, and I'm hypermobile. Okay. And my and she described a sprained SI joint
Mhm.
in her left leg. And I said, where was your left foot?
Mm.
I don't know, on the floor.
It's never just on the floor
Mm-mm.
when you're
It
driving.
was,
Yeah,
your left foot had to be on the firewall in front of you at an angle because she got rear-ended by somebody at 30 miles an hour. She was a passenger,
right.
and it was okay. So it ended up being documented the hypermobility, documenting treating the SI joint, treating her knees,
Mhm.
and the shoulder was the easiest thing. And then doing the supine cervical practicum. So the treatment only took about an hour,
Right. But it's unpacking the,
but the history,
yeah,
yeah, it was auto accidents are different
yeah,
than, oh, and only because she already had a lawyer and we already knew they were going to court.
right.
And once you're forensic, then it's this whole new ballgame in terms of documentation
Yeah.
and what you're doing. And her MD, whom I love, referred her to an upper cervical chiropractor.
Mm.
And I said, please tell me you're seeing a physical therapist. And she's ordered imaging. No. Okay, here, because the practitioner is, her MD is somebody who knows FSM. As you take her this note, this is the imaging she needs to order, and you have to see a PT. And it's like, okay, it's just, it's pretty
People
fun.
listen to you.
That sounds like a webinar thing too. It's like, what do you do when it's an auto accident?
Right. There's a whole other layer to that.
Yeah. How's your
And then
daughter?
great.
Yay.
Yeah. Healing and just so positive and just it's been great. Oh, yeah, I can breathe,
That's a good thing.
kind of. And so, yeah, that's it. So keep signing up for the advanced. We can't wait to hear how your patient walks in tomorrow. I might text you later tomorrow and see because that's super exciting.
Yeah.
But for those of us who can't text you, you'll have to just come back here next week and hear the rest of the story.
Oh, and I have to add the American Academy of Resonance Medicine. I actually have a patient who donated money to the academy. I mean, we have stuff from 2 years ago. We didn't even talk about it last year.
Yeah.
And he has been involved in starting and assisting as a director for a number of successful nonprofit institutional places.
Mhm.
And so we have the thank you letters, donation forms, and we have a donor board with little places to put people's names that donate, and we're thankful for all of it. But the American Academy, because of the how would I put it? Because of our mission to support FSM research and patient care, that's the mission of the foundation. Now, this doesn't mean, and I have to make this clear when somebody applies for donations, we're not paying for the practitioner's treatment time.
Right.
We'll pay for post-treatment imaging,
Mm-hmm.
and we'll pay for, I mean, we already pay for any fees that they charge to publish the paper, any fees that you have to pay for imaging or data collection. But that's the purpose of the foundation, and it's taken off this year. So that's pretty exciting.
So exciting.
Yay. Okay.
Okay, now we have to go, but
We
we'll
have
be
to go
back.
now. We'll
Same
see you
time,
next
same place.
week.
See you next week. Bye, everybody.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.